Steve Shack is Executive Vice President in Research and Development in Genomic Health. He was the founder, actually, of Genomic Health before he was in Genentech. And he grew and learned at New York University School of Medicine. Then he moved to California and joined Genentech, where he actually led a team that developed Herceptin, Avastin, and Pulmozyme. And then immediately after, he founded Genomic Health and actually was responsible of developing the amazing molecular diagnostic that we know as Oncotype Breast, Oncotype DCIS, Oncotype Colon, and Oncotype Prostate recently. So, Steve, please, we will start with the case study.
Okay, great.
Okay.
Well, it's absolutely fantastic to be back in Israel again. The country looks beautiful. There's so much construction and building going on. I know today, actually, I am visiting here from California. I think Netanyahu is visiting California today from here. Did we get that on the camera? He said, let him stay there and let me stay here. Actually, it's interesting. We're having a problem in California with not enough rain this year. There's been a lot of snow on the East Coast and in New York, but very little rain in California. And so I think actually the governor, Jerry Brown in California, was asking Netanyahu for advice on water management. But no, it is the 10-year anniversary, and it just is incredible. I think one of the things I do want to also acknowledge is not only your commitment to bringing genomics and putting it into practice and using the test appropriately, but I also want to acknowledge right at the front the work by Lior and the whole Teva team here. I mean, they've been a great partner to us. And so important. I tell you, one of the first times when I came here, there have been so many special memories. But with Oncotype, I remember the first time I saw, the brochures and the instructions for ordering Oncotype all in Hebrew. I sort of really liked that. So that's really nice. What's also really nice is this is the first time in coming here that we can have case presentations and have much more of an interactive discussion. In Israel here now we are making more progress elsewhere in the world, and some parts of the world, France is now starting to use the test. It took them a long time. But this is now, for us today, in my comments, I'm going to make them much more advanced. This is not Genomics 101 for us here, but we'll talk a little bit about some of the new data on Oncotype, talk a little bit also about the colon and the prostate assay, and then I'll talk about a vision for the future. What is Genomic Health thinking about? What do we want to do in the future? How will we partner together to continue to advance and ultimately turn breast cancer and other cancers into manageable diseases like infectious disease? So for today then, we have 5 presentations. And the first one, I'd like to ask Dr. Fried, could you come up and present the case? And if you could use the microphone, that way we can, and just if you can come right up, and you can come up and stand here. Yeah.
Okay.
Yeah. Thank you.
I want to see the slide. יש על
yeah.
המסך.
That's good.
Okay, thank you. So I'm presenting a patient. Now she's 56. 6 years ago, she was, of course, postmenopausal, and the tumor was 9 millimeter invasive lobular carcinoma with hormone receptor positive and HER2 negative, and the histological grade was not done because the histology was lobular and is considered to be a good histology, a good low grade. Lymph nodes were negative, and good general good performance status. So we ordered Oncotype DX. It was 6 years ago, and we received a recurrence score. The recurrence score was 26. Instead, she was 70 in good performance status, invasive lobular, a small tumor, but with an intermediate grade recurrence score. With an intermediate recurrence score, this is dilemma, what the treatment will give to the patients in this condition. So, we change the slide. Lymph center. Just a minute. So she received hormonal therapy, but because the relative high recurrence score, 26, I prescribed her aromatase inhibitors for 5 years. And she's now she's 76 years old, and she's in good health and without breast cancer recurrence, and we stopped the Arimidex, the anastrozole.
Great.
Okay.
Okay, thank you. If we have a microphone, if there's someone here that has a comment on this, I am going to present some new data in my talk on the experience in a registry in the United States on what is done for the intermediate recurrence score. In this case, though, I think what you highlighted, Dr. Fried, which was really great, is that whenever we get a recurrence score, we have to look at all of the other factors, and we have to look at the individual score. The 26 is sort of right in the middle between it's 17 or 18 and 30, so that's right in the middle. But you also identified in this case that there were the other features that were all quite favorable. The fact that there was a small size, that it was clearly HER2 negative, and that she was an older woman, and that those other factors actually would indicate that if there was a benefit of chemotherapy, and actually the goal of the TAILOR-X trial, which is now ongoing, is to give us more information on the effect of chemotherapy in the mid-range. But until we have those results, I would have been also very comfortable with the recommendation that you gave. Yeah. So, Dr. Fried, thank you very much. And I'm also very happy that she is in good health now and 76. So that is good. One of the things I saw Nikki Lieberman from Clalit, I met also when I was here with some of the people from Maccabi, and I know that there is great interest, and what we will be seeing soon is a summary of information on the experience here in terms of long-term outcomes in Israel, and that will be very important data and very interesting to look at when that analysis is done. So I think that's one of the things we really look forward to. The next case is a case that was submitted by Dr. Leviov. This is a 71-year-old patient, and near and dear to my heart, it's about HER2. Yes, thank you. Yes. Yeah, that's it. That's good? Okay.
Yes. It is a 71-year woman. She has an invasive ductal carcinoma with a tumor of 1.7 centimeter. The receptors, estrogen and progesterone, were strongly positive. 90%. The grade was 2. KI 67 was 40%. No lymph node involvement. The general health was good. And in our center, we are sending at the same time oncotype test, and because the ER2 new status was equivocal, plus 2, we sent at the same time oncotype and fish. So the fish was strongly positive. So I saw in this case that there was a discrepancy between the strongly positive receptors and the fish. So I asked a second test in an other laboratory. In this case, it was in Rambam. And in Rambam, the ER2 was at immunochemistry negative +1. And I demand to do a fish, and they did a CISH, and the CISH was 1.9. In this case of 1.9, we must, by the FDA recommendation, give chemotherapy and Herceptin. So she began AC chemotherapy, and after one course, she has fever and neutropenia and was hospitalized. And after this, she didn't want to go on with chemotherapy. So I give her Herceptin, and she's until now under the treatment with Herceptin, and she received Arimidex. In this case, I think that is a good treatment because the biology of the tumor is good.
Yeah. Okay, thank you. This case highlights the importance of knowing the HER2 status and of pursuing with the desire to get greater information when things look funny or uncertain. What do you remember, Dr. Leviov, the HER2 score from Oncotype? Was that negative as well? It was negative as well.
It was negative.
Yeah.
But we know that there is a small percentage of false negative with
Yes.
the oncotest.
Yeah.
So we do.
So you did you went to the other laboratory.
Yes.
You went to the other laboratory. So actually, in thinking about this case, I will review what we know about HER2 testing and also about the concordance. One of the things about HER2 testing is that it is not so easy. When I first went to FDA with Herceptin and the Hercept test in 1997, it was very surprising to me that the standard of the FDA, when we looked at concordance, FDA said to us at that time that having 70% concordance was good enough. And so clearly, there was a feeling then, even at the FDA, that it was quite difficult with IHC and some of the older technologies to get very high concordance, the concordance that we want for quality care. There have been now a number of international efforts to work on the methods that would reduce the amount of errors that are made in HER2 testing. So I applaud you for actually, in this case, if one has a question, I always say either with regard to ER status or HER2 status, it is so important to get that right because it can have such an effect on treatment that doing more than one test is sometimes, for some patients, the right thing to do. And And that was the case here. We have actually found, although there was one publication that reported a very high, and it seemed to me surprising, number of false negatives, we now have completed 3 large studies, one of them in 500 patients, the other in close to 600 patients. And then Dr. Perez from the Mayo presented data at ASCO a little less than a year ago. You might have seen that, looking at the N9831 trial, one of the adjuvant clinical trials. And that study showed a 95% concordance of the Oncotype DX HER2 score with IHC and with FISH, a concordance that was just as high as the concordance between IHC and FISH. So I always say, you know, what's most important is not what method you use. Clearly, the recommended methods are IHC and FISH, but that it's done in a quality way. And if you have a question, that you relook at it like you did here. Probably with a good recurrence score, she is very likely to do well in the long run. And I guess she's still doing okay now. Is she on the... It's still early. It is still early days. Yeah. Yeah. It would have been desirable. Obviously, the data does say that combining Herceptin with chemotherapy is better than Herceptin alone. But in this case, you know, you appropriately looked at the, you know, the condition, the complaints of the patient, and took that into account. Thank you. Good case. Do you all look at, by the way, question the HER2 score when you get it? Is it one of the reasons we added the ER score and the PR score and the HER2 score without increasing the price is that many physicians said, boy, this is so important. I'd love to have another look at this, even just for quality control. So is that useful then, just to look at that in every case? So we'll continue to do that. Well, now we have a very interesting case of Oncotype DX in and male breast cancer. Dr. Sami, thank you. Thank you.
Yes. I wish to present a male breast cancer. 50 years old healthy man was diagnosed with invasive disease with T size 3 centimeters, T2, with ER strongly positive, PR positive, HER2 negative, and grade 2. After his mastectomy, the node negative, he was node negative and generally healthy. So we sent for him, like female breast cancer, the Oncotype, to decide which adjuvant treatment to give him. And his recurrence score was very high, 35. And obviously we offered him an adjuvant chemotherapy. Our suggestion was 4 cycles of DC, Taxotere with cyclophosphamide. Now my question is, in these cases, in male breast cancer, they have the same biology like female breast cancer?
Good question.
This one. The second, when we have a high risk score in male and in female, generally it's enough to give him short protocols like 4 DC cycles or 4 AC cycles, or to give him the full protocol treatments like AC followed by Taxol. Generally, we offer always the short protocols. It's enough for this category of patients.
So, great questions. I'll answer the second question first and then the first question. I remember I sometimes show a slide with regard to the question of how much benefit or added benefit is there from adding Taxol to AC. And Martine Picard has a very nice slide summarizing 21 studies in more than, I think it was 31,000 patients. And some of those studies were positive, some of those studies were not positive. And clearly, if it took 31,000 patients to show a little bit of difference, the difference is not that big. And so I also am okay with shorter protocols like you used in this particular patient.
The short one is
Yeah,
enough.
and there is no evidence that I know of that says that the high recurrence score necessarily means that you have to give the most aggressive kind of chemotherapy. In fact, what it says is that generally chemotherapy works, and if you remember, even in the B20 study with the very old regimen of CMF, those results were quite spectacular. So the second question, I would be okay. Is that something that, again, is used commonly here as well? Again, choosing certainly to give AC and a Taxol would be fine too. That would have been,
We always talking about non-negative patients.
yes, yeah.
Yes, and another consideration,
Yeah.
in the intermediate category, when we
Yeah.
have intermediate risk score,
Yeah.
Some of us use the another two categories: intermediate low below 25, and
Yeah.
intermediate high above 25.
Uh-huh.
It's acceptable for you?
Yeah, when the TAILOR-X study was designed, I thought that it would be very confusing to have, a different cutoff. But the investigators in that trial had the final decision. It was not my decision. I would not have used and made it confusing by having another number, 25. So I do know that that is the cutoff that is used for that particular study. But for other studies, that cutoff is not used. And as I said, we'll probably know more about the effect of chemotherapy in the mid-range when we see the TAILOR-X results. Now, male breast cancer, it's actually very timely that you asked that question. My colleagues and I are this week also in San Diego. There is the USCAP meeting, which is the major pathology meeting for the United States and Canada in San Diego this week. And we have 5 abstracts that are being presented there. And one of them is our second report of our experience with male breast cancer. And so a poster was presented on March 5th. And so just 2 days ago, or yesterday. And so I can tell you in that poster, there were 1,446 men. So that's probably one of the largest cohorts of male breast cancer. Now, we don't have outcome data, and and that's obviously something that we wish we had, but it allowed us to do the largest genomic analysis of how similar we compared what we observed in male breast cancer to the hundreds of thousands of cases that we had of female breast cancer. And so the findings were, 1, male breast cancer was 0.5% of our submitted cases. And that's about what you would expect. Other people here have ordered the test in male breast cancer. Raise your hand. Yeah. Interestingly, the average age, this has been reported before, this patient is a bit on the young side for male breast cancer.
Yes.
The average age in our cohort for men was 63, and for women it was 58. So on average, the men were older. Also, the men were more likely to have ductal carcinoma, 86% versus 81%, and also more likely to have the papillary type, which is not very common in female breast cancer. In female breast cancer, in our experience, it was 0.6%, but 5% of the men had papillary breast cancer, interestingly. And maybe that is because if one looks at the percentage of the ducts in the man that are big, near the nipple, that percentage is much higher, and so maybe that is why you see more of the papillary type. But very interesting, I don't want to be suspense and hold the punchline. If we looked at the distribution of the recurrence scores, if we looked at the biology, male breast cancer looked very much like postmenopausal female breast cancer. Yeah.
You can make extrapolation.
Yeah. And so, the conclusion of the poster is that The extrapolation that we have done in the past is supported by the genomic analysis. And it also says that clinical trials, I think, should not exclude men from the opportunity to benefit from new investigational strategies. And so that was the other thing. So, we don't, there is no separate study of chemotherapy benefit in male breast cancer, but, this is what I would have done as well.
Thank you.
Thank you.
Thank you.
Thank you very much. Give Dr. Sami.
That's good.
Yeah, thank you. So DCIS, a whole new area for us. This, Dr. Leviov again, thank you. Yep. Great.
So she was she is a 68-year-old patient with ductal carcinoma in situ. The size of the tumor was 8 millimeter with receptors positive, HER2 negative, grade 2. The margin were 7.5 millimeter, no lymph node, and we did oncotype.
Yeah.
And the score was 47.
Okay.
So.
But let's look at this, because the page is very different for the DCIS score than for the recurrence score, right?
Yes.
So this is the score of 47 in your case.
So we decide to irradiate the breast.
Yes.
But in this case, we can see that the age is more than 60.
Yeah.
If we are compare with the Van Nuys prognostic factors,
Yes.
so the age is good, the size is small,
Yeah.
the receptors are positive,
Yes.
and the margin perhaps less than 1 centimeter.
Yeah.
And here the oncotype can help you to decide to give radiation therapy.
What would you have done, I have a question for you, if the DCIS score was 12?
12?
Yeah, if it was much lower, if the DCIS score was 12 in this case, very favorable.
Follow-up.
What? Just no radiation then, or would you still give radiation?
I want to see another time the graph.
Oh, the graph. Yeah, so if it was down here,
Low risk.
low risk.
I think that perhaps it is enough to
Okay.
do. We haven't not so much experience with DCIS and with invasive ductal carcinoma.
Yes. Good, thank you. I will comment on this. First of all, again, thank you so much. So what Dr. Leviov just said is true also not only in Israel, but also still in the United States, that there is much more experience in using the invasive test, the recurrence score, than there is the DCIS score. There also are many more studies and much more evidence with regard to the recurrence score. And the ECOG study is a beautiful study. It is very well done. I am very confident of the results and that these results will be confirmed. But it is one study. Being very rigorous and always wanting to do the best, we are doing another study right now, also back in Redwood City. There are samples now that are being processed for a large study. It's going to be over 1,500 patients with DCIS. And it's also going to look at not only patients who got surgery alone, but also patients who got surgery plus radiation. So we can also be more confident that with a low DCIS score in certain patients, it would be a good recommendation to give surgery alone without radiation. In this particular case, I would agree the DCIS score was not so low. And therefore, in this case, it would help me with the patient make the recommendation that a course of radiation would lower the chance of a possible invasive recurrence. Anyone else have any questions about DCIS? Clearly, the other thing that's very notable here is that our experience also is they are being diagnosed, and we are seeing now many DCIS cases that are very small. And I'm sure that is probably the experience here. Okay, good. Yes, a question here.
I didn't understand what is the goal of to examine the score in DCIS. Is it to go to decide upon adjuvant radiation therapy,
Yes.
or surgery alone, and that is the only indication? Or you
Yes.
think that is another indication like systemic therapy?
So
What is the evidence?
yeah, so we don't have evidence. We have evidence now on recurrence risk, and the main use, particularly for older women with favorable features. I mean, that's where many physicians have started, is by getting experience in those patients, and then using it to make a decision of radiation alone versus radiation. Surgery alone versus surgery plus radiation.
Evidence about there is a randomized trial between according to the score or something like that?
No, there isn't.
Prospective analysis on the difference between surgery alone and surgery alone?
No, in the first study, it was only surgery alone patients looking at risk. The next study we're doing is going to have also patients treated with radiation and patients treated with surgery alone, although it's not randomized. As you know, there have not been very many large randomized studies that still have the blocks and can be analyzed. The question of systemic therapy is more complex and needs to be individualized, and I wouldn't recommend using the DCIS score to decide whether to give hormonal therapy. I would not. I would not use the DCIS score to decide whether to give hormonal therapy. Sometimes we give hormonal therapy to prevent contralateral breast cancer anyway. And that often is the main reason to think about hormonal therapy in this setting.
But it's not an indication for systemic, for hormones.
That is correct. It shouldn't be used to make that decision. I think what we're highlighting, and it's really important, right? Tests are used for very specific purposes, and a test that's useful for one purpose might, be, not so good or irrelevant for other purposes. Yeah. Good. Thank you.
I have a question.
Yes.
It might be. You think that may be a difference between intraoperative radiation versus operation, post-operative radiation, as to the extent of the recurrence, later recurrence.
Yeah.
Do you think the score might show us or might direct us to which treatment to give?
Yeah, that's a great question. We don't know yet, and there is no evidence that I'm aware of that looks at that. But some of the companies that are working on partial breast irradiation are now thinking about studies that might be new and prospective, and it might make sense to actually explore that approach in patients with lower scores. And I think that's probably what you're thinking about as well. Yeah. But, so we would welcome seeing those studies. I think you would as well. Right now in Israel, are intraoperative approaches used very frequently? In some institutions.
One institution.
One institution.
In our institution,
Yeah.
We use the same protocol as the target.
Yes.
For,
Here's the microphone. Can you use the microphone? Yeah, thank you.
With Dr. Steiner, Mariana Steiner was leading the protocol.
Yes.
Women are over 60, only invasive ductal, less than 2 centimeter.
Right.
With a negative clinical lymph node.
Yeah.
Clinical and ultrasound.
Yeah.
And so far we have about 500 patients.
Okay, good. But
And
so what?
And the breast recurrence is about 3%.
Yeah.
If I'm not wrong.
And so what would you think of the idea of maybe using a low DCIS score also to help select patients?
It's hard to know because so far we have a median follow-up of about 4 years.
Yeah.
And the recurrence, the local recurrence is very low. So
Yeah.
it's really hard to know
Okay.
To add the score to this.
Okay, well, save the blocks. Maybe that is something that, could be looked at.
Partial breast irradiation so far, and there is no randomized study
Right.
to check partial breast irradiation for
Right.
DCIS.
Right. Yeah. Yeah. So,
I just wanted to ask Dr. Leviov, why was a sentinel node done with this DCIS patient, small lesion of DCIS? Bunny? Oh, because you wrote that the lymph node status was negative.
okay, thank you. Very good. Great. And for our last case, again, Dr. Fried, please. Yeah. We have a younger woman. You could.
The next patient, she's 37 years old, and she's premenopausal. She was presented at our tumor board with relatively large tumor in small breast, clinically a 4 centimeter tumor, and she was presented in our tumor board to discuss the preoperative chemotherapy versus mastectomy. And the histology at this point was invasive ductal carcinoma, but with extensive ductal carcinoma in situ, hormone receptor strongly positive, HER2 negative, and Ki67 was 30%. Because on core biopsy, DCIS was very extensive, and hormone receptors positive, and clinically she was not negative, and also the sonography of the axilla was negative for lymph nodes. So we decided the tumor was a large tumor in the small breast with extensive microcalcifications. We thought that it's better for this patient to undergo first a surgery, a mastectomy, because was the probability that the tumor is mostly DCIS and will not respond to chemotherapy, and also not spare the mastectomy from the patient. And so she underwent the surgery. The pathological areas were 4 centimeter with street invasive tumors. The largest was 1.5 centimeter and very extensive DCIS. So in the largest tumor, 1.5 centimeter, Oncotype DX was performed, and the recurrence score was 13. So we start with this patient with hormonal therapy. No, but it's only a few months. I hope she'll be okay.
Okay, good. Good. Well, yes.
Could you just comment about the Ki67?
Yes. So.
No, it's okay.
Yes, so the number of features of this case to comment on. One of the questions right now was to comment on Ki67. I actually brought along some slides that I'll show later that were generated and published recently by some major pathology groups that looked at the question of how reproducible and reliable is the measurement of Ki-67 from lab to lab. As you know, it's often performed routinely in many labs, I know in Israel, and also now even in the United States as well. And it doesn't even have to be ordered, right? It just comes automatically. And when I show the data regarding the reproducibility, I'll show you why I generally am very concerned about Ki-67 data that might be misleading. I do not recommend Ki-67 for treatment decision making. It's sometimes interesting as part of research studies, but for individual patients, I don't recommend it. What I do want to do also, though, in this case...
Press any key.
Oh, I see.
Press any other button to cancel.
Oh. No? Thank you very much. So I'll talk without this. And so what this case also highlighted, I really like this, Dr. Fried, is some people, when I started out and did, and committed to doing genomics, so there were many people in the lab that said, genomics is going to completely... Okay. We're almost there. This is the last one. This is a great case. Yeah, good. So again, a large tumor in a young patient. And one of the things that some scientists said is that genomics was going to replace pathology, that it was going to make us and cause medicine and make it now possible to treat based on the numbers, that genomics would be a recipe and would be the only thing that you would have to look at. And I think this case highlights, and it's very important, and this will not change, that genomics has to be interpreted within the context of good pathology data. And so clearly it was important in this case to do good standard pathology, to look at the complex patterns, to identify the foci of invasive cancer in that larger lesion, and then to make sure that our pathologists, when they did the recurrence score carefully, did the manual microdissection to make sure that we did the analysis of the invasive cancer. And that's, again, very important. Also, the clinical features in this case were important to you as well as you thought about the treatment recommendation. And so I will say, even though genomics will become, and I'll talk about the future, more spectacular, we will still, as physicians, have an important role in thinking not only about the genomics, but also about the clinical factors, the pathology factors, and also the patient and their preferences. And that will always be important in our recommendations for care. Okay? Yes? So I'll answer the question about young women in two ways. There's a psychological component of breast cancer and also a scientific component, and they're both important. Based on the biology and the evidence and the clinical studies, I do not believe that the number of birthdays, age, itself is a strong factor in terms of the biology and whether or not a patient should be treated with hormonal therapy or hormonal therapy plus chemotherapy. I believe that the recurrence score teaches us about the biology of the tumor and that that's the most important factor. On the other hand, the psychology is different in that a woman who is very young is going to have many more years to have potentially the consequences of a recurrence. And therefore, I think psychologically, sometimes we are more aggressive, especially if they're very, very young in their 20s and their 30s. Is that the experience here in Israel as well? Yeah. Yeah. But I still think the Oncotype is still an important test regardless of age. The other thing I sometimes get asked is, what about, older women who are in good health and who can take chemotherapy? Should we be testing and looking at patients who are 73, 74, 75 at the other end? And the answer there, I think, is also yes. And in particular, the data there that is very important is with high recurrence score disease. Finding that is important not only because there's a higher rate of recurrence, but if one looks at the B14 New England Journal paper, in high recurrence score disease, it's interesting, most of the recurrences occur in the first 3 to 4 years. And so I say to someone who's 73 and 74 in good health, if they have another good 10, 15 or years or more, it would be a very big deal for them to have an invasive recurrence in the next 2 to 3 years. That would very much impact the quality of their life. And so I think it's important to look for that, because that, even though most patients will, or many more patients will have low recurrence scores and hormonal therapy is fine, for some of them there'll be a clear benefit of adding chemotherapy.
What is your cut line with age?
I don't have a...
Say she's 78 or
It's,
79 or 80.
as I'm older, I don't have a cut point for age anymore.
Somebody who comes to your clinic, she's 80 years of age, she's in good health, and the score is high.
If the score is high, the data would say that she has, with hormonal therapy alone, as high as a 30 to 40% risk of invasive breast cancer in the next 2 to 3 years. Why wouldn't you want to delay that or reduce that percentage if she's in good health? And obviously, I think what we all do is we look at patients, and we do know that there's some 60-year-olds who look like they're 80, and some 80-year-old patients who look like they're 60, and yeah. You by the way look like you're 35, but yeah, I know. Yeah.
Is there any nomogram, or maybe in the future?
Ah, great.
The age and the recurrence score, and so you can predict, or you can recommend to the patient, look, what is the according to the nomogram, I can predict what is the recurrence score, what would be, and when you take in account the age of the patient.
Yeah, great question, and actually what we've... Yeah, so for nomograms, right now what we do is we tend to look at the other factors, and we do it qualitatively when we integrate it. We did recently publish a study where our biostatisticians, who are very smart and have a great creative approach, created a nomogram that we call RSPC, RS Pathology Clinical, that includes, and you put in the age of the patient, the grade of the tumor, the size of the tumor, and the recurrence score. And it shows you how the recurrence risk might shift based on those factors. If you would like that, actually, we are now offering that on the internet for as a test for about 100 physicians in the United States, and so far the response has been very positive. And so we will go back, if that is of interest, and see whether or not that could be made more broadly available. Thank you. Good question. Good. Okay. Good. Well, I think what I'd like to do now, if you could move the slides to the other presentation.